Alrighty, this is the textbook of radiographic positioning and related anatomy, the 11th edition, and this is chapter 7, which covers the femur and the pelvic girdle. This first lecture from this chapter is going to be about the intro, the anatomy, and the femur. If we look at this picture, which comes from page 268, this is the entire lower limb. In the last chapter, we covered toes, foot, calcaneus, ankle, tib fib, and knee. This chapter covers femur, hip, and pelvis. Okay, so looking at this anatomy, if we look at the proximal femur, this is figure 7.2 on page 268, and this is an anterior view of the proximal femur. This is a posterior view. So you can see of the femoral head, the femoral neck. This is where most fractures occur, is at the femoral neck. And then we have the greater and lesser trochanter. This is the body or the shaft of the femur. When we look at the posterior aspect, we can see that we have the greater and lesser trochanter, and then in between the two, only seen from the posterior aspect, is the intertrochanteric crest. So again, the intertrochanteric crest is only seen from the posterior aspect of the proximal femur. When we look at the angles of the proximal femur, this comes also from page 268, but when we look at that, we notice that it references that the angle of the neck of the femur to the shaft, so between the neck and the shaft of the femur on an average adult, it's approximately 125 degrees with a variance of plus or minus 15. Okay, it depends on the width of the pelvis and the length of the lower limbs. So a person who has really long legs and a narrow pelvis, the femur is going to be closer to vertical. But on someone that's shorter and has a wider pelvis, that angle would be less, more like 110 to 115 degrees. So a long-legged person with a narrow pelvis, their angle of their neck would be about 140 degrees. So when they say plus 15, that would give you the 140, minus 15 would give you the 110, 110 to 115. The other angle that they reference is looking at it in relation to the pelvis, and they tell you that the 15 to 20 degree anterior angle of the head and the neck in relation to the body of the femur. The head of the femur projects anteriorly or forward as a result of this angle. So the femoral head actually projects anterior or forward. And the reason that's important is because when we are positioning the femur and the lower leg, you have to actually internally rotate the leg 15 to 20 degrees to place the femoral neck parallel to the IR in order to get a true AP projection of the proximal femur. So you're going to hear me reference that quite a few times. The reason that we rotate the leg 15 to 20 degrees medially or internally is to place the femoral neck, which is this area right here, parallel to your IR. So again, the neck to the shaft of the femur, plus or minus 15 degrees, on average 125. The longitudinal angle is about 10 degrees, and the anterior angle is 15 to 20 degrees. When we look at the internal versus external rotation of the foot, what happens is when you internally rotate the leg, okay, so internal rotation, you definitely can see the greater trochanter, but notice that the lesser trochanter is non-existent, or it would be barely visible. When you externally rotate the leg, Then we start to lose some of the greater trochanter, but the lesser trochanter becomes more visible. All right, and this is actually referencing the picture on page 276. So the internal rotation would be figure 7.27, and it shows you that you can visualize the greater trochanter, lesser or barely visible. The external rotation, this would be figure 7.29. You definitely can make out the lesser trochanters, but the greater trochanters start to be a little less visible in figure 7.30. So again, page 276 for reference. When we look at the anatomic position, which is figure 7.25, notice that they're telling you when the patient is in anatomic position, the long axes of their feet are vertical, the femoral necks are going to be foreshortened, and the lesser trochanters are partially visible. But you definitely foreshorten the femoral neck right here, which is not what we want. When we look at a true AP, where we internally rotate the feet 15 to 20 degrees medial, then what you end up doing is making the femoral neck parallel to the IR. The long axes of the feet are internally rotated 15 to 20 degrees. The femoral head and neck are in profile and parallel to the IR. You get a true AP of the proximal femurs, and the lesser trochanters are barely visible on here. So that is, the greater are definitely pronounced on both, lesser are barely visible. So this is a really good AP of the proximal femur, which is also looking at the hip. In this actual image would be a pelvis. When we look at external or a relaxed position, again, it foreshortens the femoral neck significantly, and the lesser trochanters become far more visible, which is not typically what we want to see. And last, when there is asymmetric rotation of the hip, meaning that when the asymmetric rotation, not of the hip, of the feet, meaning one foot is vertical and the other foot tends to be flopped out, and usually that leg appears slightly shorter. This is typically indicative of a hip fracture. So the affected limb tends to appear flopped to the side, and it usually is a little bit shorter because the muscles swell and tighten to try and maintain typically the fracture. So you can see here, compared to this one, the femoral neck is where the fracture is, and then that femur is actually shoved up towards the femoral head. So this is definitely indicative of a fracture, and a lot of times this is how your patient will present. So if the patient presents like that, you typically are just going to take an image as they are and kind of see what you're dealing with before you move forward and try to move them in any way. The concern with moving a patient with a suspected hip fracture is that you could possibly sever the femoral artery, and we never want to make the patient more cause the patient more damage than what they came in with. So anytime a patient presents like this, you kind of have to assume that there's a hip fracture, take an image and see what you're dealing with before you move forward with anything else. As far as the shielding guidelines, these are on page 277, okay? And gonadal shielding, according to the registry, is still supposed to be applied. You'll notice that the book tells you the use of gonadal shielding is subject to local regulations, department protocol, and policy. So this is showing you male gonadal shielding, a small contact shield, and the top border of the shield is placed at the inferior margin of the symphysis pubis because the male gonads tend to lie below the pelvis. The testicles lie below. So male shielding is acceptable and advisable if that is what protocol dictates. on hips and pelvis and femur. So a male patient can be shielded, and the registry will still test on that, even though where we are, gonadal shielding has pretty much gone away. So we focus on collimation and appropriate radiation sparing dose. When we look at female gonadal shielding, this picture is figure 7.35. Um, this shows that this right here, when they talk about doing a unilateral hip or the proximal femur, you can cover the general pelvic area without covering the specific hip being examined, and that's what this is showing. So they've got the shield ideally protecting the region of the ovaries. They've got the shield protecting here, and the area of interest would be the proximal femur or the hip of the right side. Okay, but again, we do not, in our region, we do not use shielding on any patients. This is just showing you what the registry would ask about and expect as far as testing purposes. This female gonadal shielding, this is referencing figure 7.34, even though the picture is different. So this is strictly an ovarian shield for when you are imaging hips and the proximal femur, but technically this is going to obscure anatomy, so it does not mean that it's ideal to be used. It's just saying that you are able to, if you're literally just looking at the hips and the proximal femur, there is a possibility that you could use female gonadal shields, because remember, the ovaries lie above the pubic symphysis, so this would obscure anatomy. So again, it is not recommended, but all males can have gonadal shielding for hips and pelvis and femur images, but female shielding is not really likely unless you are told that you are able to do something like this and obscure the anatomy. When we look at the femur, the routine positions for a femur, there are 4 positions on a femur, and technically 2 of these, the AP proximal and the lateral proximal. So these 2 images, this one, AP proximal femur, and lateral of the proximal femur, both of those images would be a hip. An order for a hip, you would get those 2 images. But when they order a routine femur, there's no way to fit the femur on one IR. So you do 2 images of the distal femur and 2 images of the proximal femur. Okay, so a routine femur has 4 views, 2 views of the proximal and 2 views of the distal. All right. When we look at the AP mid and distal femur, this would be the first image you would do, and this is on page 280. The technique, which is nice for all of these images this week, we are using 80 kVp at 12.5 mass. Okay, 80 at 12.5. So on this AP of the mid and distal femur, you can see the femur is a long bone, so you need the joints at both ends, but you're never going to fit that on an adult on one IR. So you start by capturing the knee joint and as much of the lower femur as you can. So you're at a 40-inch SID. You're on a 14 by 17 collimated field. The patient is lying supine with the femur of interest ideally in the center of the table. You rotate the patient's leg internally about 5 degrees for a true AP, just like when we're doing an AP knee. Okay, now this is for distal femur. You make sure that the knee joint is occluded on the IR. Central ray is perpendicular, and it's basically you include the knee joint, so wherever that ends up, as long as you have the knee joint at the bottom of the IR, then that is acceptable. in this image, you have to display at least the distal 2/3 of the femur, including the knee joint. And the knee joint is not going to be open because of the divergent x-ray beam, and you're not angling the central ray. Okay, so this is an AP distal femur on page 280. When we look at that, again, we have the knee joint not open because our central ray is not parallel to the tibial plateau like it should be for a knee. It is simply perpendicular to the middle of this IR. But we capture the knee joint and we get as much of the distal femur as we can, along with our marker on there. The AP proximal femur is all the way over on page 291. So this, remember, this would be your second image. This is also considered an AP unilateral hip. So if they order a femur, this would be your second image. If they ordered a hip, this would be the first image that you would do. Okay, so this is 40-inch SID. You're collimated to a 10 by 12 portrait. Your technique is still 80 kVp at 12.5 mass. Patient is still lying on their back, and you are going to locate the femoral neck, and you are going to internally rotate the leg 15 to 20 degrees so that you get a true AP. But you only rotate the leg if the patient is able to. If you really suspect a fracture, look at the foot placement. If it's flopped out, do not internally rotate the leg. So if you really strongly suspect a fracture, just shoot it however the patient is. If they walked in and they're just having femur pain or hip pain and they walked in on it, then you can most likely internally rotate that leg 15 to 20 degrees. And the central ray is perpendicular to the femoral neck. Okay, now how do we find the femoral neck? So we're going to move away from this image just so you know. The femoral neck is found, there's two ways to locate this, and this is actually on page 275. So the first way we do not do this. We literally go by this method here, method 2. So they tell you in method 2, you find the ACES. So this X is on the ACES, and you're going 1 to 2 inches medial, and then 3 to 4 inches down from ACES. Okay, so 1 to 2 inches medial, 3 to 4 inches distal to the ACES, and that should place you at the femoral neck. That's what that N stands for, femoral neck. Okay, so our central ray on an AP proximal femur is perpendicular to the femoral neck, and if that is done appropriately, then you should get at least 1/3 of the femur. You will get the hip joint space where the head of the femur sits in the acetabulum. The lesser trochanter should be barely visible or not visible at all, as it is in this image. Greater trochanter is visible. If you had a patient that had a prosthetic hip, if they had a prosthesis like on page 291 in figure 7.7, recognize that you have to demonstrate the entire prosthetic hip in one image. Now, if they had a rod going down the length of their femur, then that would not be possible. But if you look at figure 7.7, and that patient had one of those types of prosthetics, you would have to include the entire prosthetic in one image. All right, so central ray is perpendicular to the femoral neck. That way you get a true, by internally rotating the leg 15 to 20 degrees medial, you will have the femoral neck parallel to the IR, and then your central ray is perpendicular to that femoral neck. and that is found by locating ACEs and going 1 to 2 inches medial and then 3 to 4 inches down. Okay, 1 to 2 inches medial from ACEs, 3 to 4 inches down from ACEs. That is an AP proximal femur. Next, we have the unilateral frog leg, or the lateral of the proximal, and this is on page 294. All right, now this image right here does not look like the one in your book, but the next image will be the one in your book. So what we need to do is abduct. We're going more for this, not this one. Okay, so you abduct the femur 45 degrees from vertical, and that will best demonstrate the femoral head and acetabulum. I'm sorry. If you abduct the femur 45 degrees from vertical, that's what we do. That one will literally demonstrate the proximal femur region, and it's usually done for just general survey. If you wanted to demonstrate the femoral head and the acetabulum, then you would abduct the leg 90 degrees from vertical. So their leg would lay all the way completely out, knee bent, hips, both hips flat on the table, meaning they're not rotating their pelvis, they're just letting their leg go 90 degrees from vertical. Right here, this is 45 degrees from vertical, and typically that is a general survey proximal lateral femur. Whew, that's a mouthful. So this is 40-inch SID, still collimated to 10 by 12 portrait. Your technique is still 80 at 12.5. We flex the knee, we abduct the femur 45 degrees, and the central ray is again perpendicular to the femoral neck, which is found 1 to 2 inches medial, 3 to 4 inches distal from ACES. When this picture right here, so this is the one we typically do for general survey, not this one. And this next image, they do show you this with the patient standing because they reference that this is typically done as a lateral hip on a non-trauma situation. You could stand them, but this is typically when patients come in with femur or hip injuries, rarely are they walking in. This might occur at an orthopedic center. Typically they're coming in on a stretcher or they're lying on the table, and this is the view that we would do, this little inset picture here. And it's also called, so it's a medial lateral projection because you're entering medial, exiting lateral. This is an a lateral proximal femur, and it also can be referenced as a modified Cleaves method. Okay, all of this again is on page 294 of your textbook. When this is done correctly, you should visualize the entire femoral head, neck, and trochanters centered to the IR. The femoral head and neck should be in profile, and this is 45-degree abduction. If you wanted to not distort the femoral neck as much, you would only go 20 to 30 degrees. And again, 294, this can be called a lateral proximal femur. It's also a unilateral lateral hip, or it is also called a modified Cleaves method. The next image we would do is a lateral of the mid and distal femur, and that is all the way back on page 281. Still 40-inch SID. Now you're opening your collimation to 17 inches in length, and you're probably still collimating a little bit from side to side, but this right here would be 17 inches. You're still 80 at 12.5. You're going to have the patient flex their knee approximately 45 degrees and roll their leg out towards the affected side. And you're going to adjust the patient so that you include the knee joint at the bottom of the IR. But the most challenging thing with this is you try to have the femur run with the long axis of the table, meaning you have to constantly scoot them back and get this leg to be straight and ideally in the middle of the table. The central ray is again perpendicular to the midpoint of the IR, because on this you have to capture the knee joint. So wherever your central ray ends up that you are capturing the knee joint, that is where you would be. So there's no specific point. In order to have this done properly when we evaluate it, you should have the distal 2/3 of the femur, including the knee joint. And again, the knee joint will not appear open. This femur should be centered, and you have to have at least 1 inch beyond the knee joint. Okay, this image does not go with this, because this is saying lateral, mid, and proximal. So here you can see as proximal and they've got mid, but what we're going for is more like this, where you have a lateral of the mid and distal. Now, from learning knee, notice that the femoral condyles are not superimposed, but remember we talked about when they're not superimposed because they sit superior and inferior to one another. That is because the tube is not angled, because the medial and lateral condyles, there's about a 5-degree difference between them, and that's why we angled the tube 5 degrees cephalic on every single patient for a knee. So because we're doing a lateral of the distal femur and including the knee joint, we are not going to have these superimposed because there is no angle on the tube. So knee joint included minimum, no rotation, ideal exposure factors. If you have a patient that is a trauma patient, then you're going to do an AP of the distal femur, an AP of the proximal femur, a cross-table lateral of the distal femur, and a cross-table lateral of the proximal femur. Okay, so the AP of the distal is just exactly like we looked at for the first position of the femur on page 280. The leg is internally rotated 5 degrees to get a true AP. We capture the knee joint and as much of the femur as we can. Then we go on and do an AP of the proximal femur, which is an AP unilateral hip on page 291. This one, the leg is internally rotated 15 to 20 degrees medial to place the femoral neck parallel to the IR. The central ray is at the femoral neck perpendicular, so that is found going 1 to 2 inches medial from ACIS and 3 to 4 inches down from ACIS. And again, if done correctly, you would end up with your image looking like this. So those two are normal for a trauma femur. But then if it is trauma and the patient is not able to move, or you're significantly concerned about fracture, then we would do a cross-table lateral, which is also back on page 281. You can see in this image they have the patient lying on their back. The IR is placed between the patient's legs. The affected leg is elevated slightly, and you're going to capture the knee and as much of the distal femur as possible. And when that is done, that will give you the lateral, a cross-table lateral of the mid and distal femur without rolling the patient. So that image is equivalent to figure 7.39 on page 281. And then our last trauma view is called an axiolateral or an infrasuperior projection. The technical term for this image is called the Dennelius-Miller method. Okay, Dennelius-Miller method. You are actually shooting cross table to get a lateral of the proximal femur. You can see by this patient, realistically, you are shooting right into the crotch of the patient to get this lateral. So a lot of times, though you will not find this on the registry, a lot of times this is referred to as the crotch shot. It's not very nice, but that is literally what it is called, is a crotch shot. So an axial lateral infrasuperior projection, or the Dennelius-Miller method, is a cross-table lateral of the proximal femur or the hip. So this is done for trauma situations. You can see in this picture, both of these are on page 292. So you are at a 40-inch SID. Ideally, you are 10 by 12. To us, it looks landscape, but it's actually portrait to the patient. So it's portrait to the long axis of their femur. All right. Patient is typically on a stretcher for this, or possibly on a bed. What you're going to do is, first you want to make sure that there's no rotation in the pelvis. So you put your hands on their ACES and you make sure that their ACES to tabletop heights are equivalent. If they are equivalent, then there is no rotation. Okay. The first thing you really should do, though, is place the IR in the crease above the iliac crest, all right, and adjust it so that it's parallel to the femoral neck. So it typically sticks out just like you're seeing here. You would put the top or the edge of the IR above the iliac crest in that crease that you feel, and then this would be splayed outward like that so that it's actually parallel with the femoral neck. So you place the IR first, check and make sure there's no rotation of the pelvis next. Then you would do that first bullet point where you would flex and elevate the unaffected leg. So you would elevate, flex, bend the unaffected leg so that the thigh is near vertical and outside the collimated light field. All right, and that last bullet point where it says internally rotate the affected leg 15 to 20 degrees unless contraindicated, you absolutely are not doing that, because if you're doing the Dennelius-Miller, you already suspect there is a fracture, or you've confirmed there's a fracture. So there will be no rotating of the affected leg. The central ray is perpendicular to the femoral neck and perpendicular to the IR. The IR and the femoral neck are parallel to one another. So this is asked quite often on quizzes, tests, and the registry. In the Dennelius-Miller method, the femoral neck and the IR are parallel to one another. The central ray comes in perpendicular to the femoral neck and perpendicular to the IR. Okay, so they're showing you this on a stick figure. You can see here, this is what I mean about how right above the patient's iliac crest, that edge of that IR is in there. It is splayed outward like that so that it would end up running parallel to the femoral neck. This leg then gets elevated out of the way. Make sure your ACES to tabletop heights are equal. And then your tube is actually right here. And your central ray is coming in perpendicular to the femoral neck and also perpendicular to your IR. For another visual of what that would look like, sometimes you'll see the patient will lay like this. You notice there is significant OID, but now you can see how the tube is actually angled towards that patient. So this central ray is coming in into the crotch of the patient, perpendicular to the femoral neck and the IR. And if done correctly, then you end up with a lateral view of the proximal femur or of the hip, but you haven't rotated the patient. You've simply rotated the tube and gone cross table to capture this. You need to visualize the entire femoral head and neck along with the trochanter and the acetabulum, and any prosthetic device needs to be shown in its entirety. All right. So this is done quite often after patients have hip surgery. This is done portably in the OR recovery room, and this is done in the department if it is suspected that the patient has a fractured hip. All right, so again, just to wrap up, when we talk about femur, there are actually 4 views to a femur. There is an AP of the distal femur, AP of the proximal femur, a lateral of the proximal femur, and a lateral of the distal femur. Out of those 4 images, 2 of them are actually what are included in a routine hip. So the AP of the proximal femur and the lateral of the proximal femur are your 2 hip views that we do when they order a hip on a patient. So if they ordered a right hip, we would literally do a right AP proximal femur and a right lateral of the proximal femur, because the proximal femur is your hip. So feel free to go through and review all of the anatomy in this chapter of the femur itself. We will be looking at hip and pelvis in another lecture from this chapter. Um, there aren't really specialty views of the femur, but there are, if you notice, multiple specialty views of the pelvis and the acetabulum that we will be mentioning in the last lecture that goes with this chapter. But make sure you take good notes. If you have any questions or comments or concerns, please bring them to class. And next time we will meet, we will hopefully clarify everything. Alrighty, this concludes the lecture. Thank you so much and have a great rest of your evening.